Good evening, ladies and gentlemen. We welcome you to the Royal Albert Hall for the Journal of Wound Care and World Union of Wound Healing Societies Awards 2020.
And our next award of the evening is the Cost Effective Wound Management Award, kindly sponsored by Hartman. So I'd like you to welcome Adriana Bordeanu to join us to present the award. Welcome.
And so, on the short list for this category, we have Tissue Viability Team, Derbyshire Community Healthcare Foundation, NHS Trust, United Kingdom. The Time to Heal program was designed to improve leadership skills with a focus on quality conversations, improved education and leadership, and tissue viability mentorship. Derbyshire Community Healthcare Foundation Trust identified that community nurses were spending 50% of their time on below-knee wounds. As a consequence, a lower limb improvement lead nurse was appointed and a prevalence audit performed, which identified 851 patients with the various leg ulcer types. The next finalist is Dr. Emanuele Cerada, WUWHS Dietetica e Nutrizione Clinica, Fondazione IRCCS Policlinico San Matteo, Pavia, Italy. Dr. Cereda conducted the oligoelement SOAR trial study, which showed that supplementation with a disease-specific nutritional formula enriched with arginine, zinc, and antioxidants improves pressure ulcer healing in malnourished patients compared to an isocaloric, isonitrogenous support. And Laura Hallas-Hoyes, lead tissue viability nurse specialist, South West Yorkshire, Partnership NHS Trust, United Kingdom. Laura and the Tissue Viability Service in Barnsley has developed a new pathway to treat leg ulcers more efficiently and, as a result, has saved the NHS over 5 million over the last year. The Leg Ulcer Care for Nurses pathway, launched in June 2018, gives community nurses guidance on how to care for leg ulcers in line with national best practice standards, which are designed to improve the quality of care by reducing variations in treatment. The bronze place finalist is Dr. Emanuele Cerada from Italy. The silver place finalist is the Tissue Viability Team, Derbyshire, United Kingdom. And the gold medal winner at this category goes to Laura Hallas-Hoyes, United Kingdom. Please welcome Miss Laura Hallas-Hoyes.
Thank you very much. This is absolutely fantastic news. I'm just really happy to have been, considered, and yeah, it's just brilliant. Thank you so much. So I'm Laura Hallas-Hoyes. I'm the lead tissue viability nurse working in Barnsley community, which is South Yorkshire in England. I enjoy doing my job every day. I love little bits of everything really. The day-to-day planning, the communicating with the nurses, with the patients and my team. And it's the ability to try new ideas and bringing my team's vision, for example, to an event to completion, like we have done for this award. It's like building and coaching my team and other nurses, producing educational and interactive experiences. There's obviously in tissue viability, there's challenges every month, and there's a need to learn new technologies and better myself in order to deliver expected requirements. Yeah, so what we've done in Barnsley community over the last few years, we've implemented a best practice leg ulcer pathway, and we've seen absolute massive changes in practice. So we now have patients in full therapeutic compression being used. We've got self-care solutions being used as first-line treatments. We've got healing rates have improved. We've got a reduction in the number of appointments per week. We've had a higher number of patients in clinical appropriate compression systems, for example, patients who have got for edema controlling. In regards to releasing time for care, we found that at the 40-week healing point, 90% of patients had healed and 10% were progressing since we've put patients onto our best practice pathway. So it's more looking at developing further wound care guidance and education to assist my colleagues and patients in wound care needs in different ways to what we're currently using, using more online training, more face-to-face on Teams. And it's particularly looking at the need for supported self-care treatment plans and patient education moving forward to encourage more self-care and supported self-care for those patients. So obviously the pandemic's currently taking priority, and therefore the challenges is ever building the number of wounds within the community setting, and the challenges we're facing now is so supporting the nurses to assist in the treatment and the care of patients is paramount. Because patients aren't getting admitted for treatments because of the pandemic, we've got a massive backlog in the community setting. So it's supporting those nurses on a day-to-day basis. We're caring for the patients as best as we can.
Next up, we have cost effectiveness models, how it can improve outcomes in patients with hard-to-heal ulcers. Brought to you by Dr. Vladika Velikovic, Global Senior Health Economist. Before we start our webinar tonight, here is a short presentation from Hartmann, who've sponsored this evening.
So, my name is Peter Schurk. I'm VP Sales Marketing for the Global Commercial Operation for Hartmann Group in Wound Care. And we are coordinating with my team globally, basically the fields of market access, pricing, sales force efficiency, downstream marketing, as well as, very importantly, medical education. Hartmann is active in three major fields of healthcare. It's incontinence, it's infection prevention, and wound care. We are looking back to a history of around 200 years. And in particular to wound care, it's very important to mention that we have been cooperating with healthcare professionals and scientists back in the time in improving their antiseptic wound treatment, and industrialized as a first company their sterile wound dressings. Within the wound care segment, we are basically offering one of the widest assortments in the industry, from traditional over advanced wound care up to negative pressure, being ready to get for patient treatments in various indications, in almost all indications possible. Some of our well-known power brands I can as well mention, like the ES compresses as a sterile cloth compress, or the PR Haft, they are very well-known bandages, as well as Hydroclean in advanced wound care, Cosmopore in post-op, or of course Cetavit Plus and Cetavit Plus Silicone in the field of the super absorbers. Yeah, we are always keen to support initiatives challenging the status quo and going for the extra mile to do something better, to achieve a greater good for wound treatment and for treatment outcomes. And we have seen this initiative as a very could want to give a perfect platform and recognition for the people going really for the extra mile. And yeah, that was their decision then to support this excellent initiative. Yes, basically we have been fighting on two ends of the problem. So number one was that we wanted to ensure that all the products reaching the patients and we can maintain the treatment pathways and the protocols. We have been working hard to keep up and run hundreds of thousands of patient treatments in the last months. The second challenge for the company for wound care was definitely to find the best possible way to keep the communication up and running in a safe and efficient way with the healthcare professionals in these really difficult times. Yes, excellence in wound care I would define on two basic parameters. Number one is to improve outcome, so basically accelerate the healing. And the second would be if a complete healing is not possible out of different reasons, then at least increase the quality of life. So outcome and quality of life, that would be the two parameters I would define excellence in wound care. As I mentioned already, I mean, challenging the status quo and improve the treatment outcomes and care is definitely a primary definition of innovation and development. However, I would also mention and underline the fact that the development is worth nothing if the access is not for everybody, just for few. So if the innovation and development is not accessible by the mass of patients, but only by few, then the development is worth nothing. So I think these two factors are important to mention. Yeah, I think you heard it already many times, also within these interviews already. Actually, the advice what I'm following every day is challenging the status quo permanently to achieve a greater good. So, and this is what I'm following, and that was the advice I was given, and yeah, I can just live with it very well.
Hello everyone, and welcome to our webinar. My name is Lajca Veličković, and today I will talk about cost-effectiveness models and how they can improve outcomes in patients with hard-to-heal ulcers. Before we start, let me shortly introduce myself. I'm working at Hartmann Group as a global senior health economist for wound care. And by education, I'm a medical doctor and I'm pursuing my PhD in health technology assessment. My research interest is in the field of health technology assessment and related field as a decision analysis, causal inference, and clinical risk prediction. Today's webinar will be relatively short, 15 to 20 minutes, but with ambition to cover three important aspects. One is the terminology itself, specific terminology we use in cost-effectiveness modeling, as well as in related field of health economics and health technology assessment. In the second part, I will try to explain why we need the models in general in healthcare and in the wound care. And in the third part, I will explain a bit more why we need particularly cost-effectiveness models in the wound care. Every scientific and clinical discipline has a specific vocabulary. Let's try today to introduce the most important concept in health economics. Today we will introduce 5 very critical concepts. Those concepts are health technology assessment, health economics, decision analytic modeling, cost effectiveness analysis, and budget impact analysis. Those are really general concepts, but they're really important because they're really oftenly misunderstood in their scope, but also in their aim. So let's start with the first and most general one, health technology assessment. In health technology assessment, by technology, we are referring to any preventive, screening, diagnostic, therapeutic, or rehabilitation method we are using to help our patients. So that can be drug, can be medical device, can be digital technology, whatever we are using to help the patients. Therefore, we don't want to assess the technology only from one aspect of the benefits that technology can bring, but we want to access the technology from all different domains which are important for population health. And those domains are benefits, of course, but also risk associated with using these technologies, harm for the patient like adverse events or complications. But we also want to take in account costs because that imply really serious issues with equity and equality in healthcare, and also with how we spend our budget in healthcare. Therefore, because in health technology assessment, one domain we want to access with full attention is the cost as well. We have the subfield of health technology assessment, which we called health economics. What is the health economics? I think there is also misconception about health economics because the first impression and first hint about health economics will be that that is something which we using to save the money. But actually, that's not really true. Health economics is a science of scarcity, and the aim of health economics is to obtain maximum value for money. What does that mean, actually? In the healthcare, as in any other field, we are limited with finite budgets. So we cannot spend unlimited budgets. Because we have limited budgets, we must spend them on the most smart way. And the health economics is trying to provide the method how to spend your budget on the way that you will maximize effect for your population. So that is the really health economics. And because there is many health technologies, health economists should answer the really complicated questions, which of those technologies should be used and how to balance their benefits, their risks, and their cost in order to get maximum for population. Therefore, in health economics, we are using quantitative methods to make those calculations, and those quantitative methods are decision analytic modeling. Decision analytic modeling, it's not exclusively right, so to say, of health economics, because decision analytic modeling we can use purely to define our clinical decisions without even assessing the cost. So we have many technologies and we have multiple alternatives for one treatment option, and we want to know which one is the most beneficial for the patient in terms, let's say, of their benefits and risks. And then we can use decision analytic modeling to answer those questions. Of course, we can also add the cost to that equation. And when we add the cost on top of benefits and harms in decision analytic modeling, then we are talking about next concept, which we are calling cost effectiveness analysis. What cost effectiveness analysis are doing? Cost effectiveness analysis is actually trying to answer the question, which intervention or interventions are the best value for money? The cost effectiveness analysis do not try to answer the question, can we afford it? That is the question which we answer with a budget impact analysis. Therefore, to conclude, those are really important concepts to understand and distinguish in order that we have the same understanding of the problems in wound care. Now, when we explain and clarify most important concepts, let's then dive a bit more in health economics itself. So today, modern medicine and healthcare system around the world are faced with an increasing demand on limited resources.
To continue more closer with hard-to-heal ulcers itself and how much treatment of hard-to-heal ulcers cost per year, here we are presenting three important countries, US, UK, and Germany. Quite representative results from all those three countries, showing us really high cost of hard-to-heal ulcer treatments. In the US, that is almost $100 billion only from Medicare. so meaning that the spendings are much more higher than that. Then in the UK, they are also reporting that they're spending more than 2 billions for those ulcers who healed that year, but for those ulcers who didn't heal that year, they are spending even more, 3.2 billions. And then Future Own Germany, it's reporting how much that costs them per patient, and that is a sum which is average is 10,000 euros. So we see that those costs are really, really big, and they become quite unburdened for the payers who want to address them. However, the costs are even projected to increase more because the baby boomer generation is entering the risk group for hard-to-heal ulcers. So reducing or at least controlling those costs, not to go even higher, it's a hard task, mostly because it's not so simple to see where you can reduce those costs. Let's say just these results from UK showing you that if you have ulcers which heal that year, they cost less. So meaning if you will reduce the cost of treatments, you can cause that more ulcers will be not healed that year. So meaning that you will even increase the cost, knowing that cost of treatment is just one part of the overall cost, and in terms of dressing, that is less than 10% of overall cost of treatment of chronic wounds. So the situation is a bit more complex and requires future analysis.
On the other hand, current guidelines recommendations are in line with a holistic approach in management to hard-to-heal ulcers. That means that you don't look only on certain patient characteristics, but you are really holistically approach a patient in order to treat his wound according to guidelines recommendation, taking in account not just wound-related factors, but also patient-related factors, environment-related factors, and keeping all that in mind that you need to deliver the care which is available, value-based, sustainable, taking into account equality, equity, and taking into account that should be that you deliver cost-effective care. That is not really easy goal because we know from medicine in general, whenever you are introducing personalized medicine approach to treatment of patients, and this is a personalized approach, this is not approach one fit all, but you're using really specific patient characteristics and spectrum of different characteristics in order to decide and treat on the right way. Whenever we do that in the medicine, we need to introduce more testing and more time with patient and sometimes more advanced treatments, and that in overall cost more. And the biggest hurdle and biggest goal is to how to do it in the way that you can balance between what you want to achieve with the patient and existing budgets and cost of treatment. And the only way is to answer the question which we have on the first slide when we present terminology. We say cost effectiveness analysis are answering the question, what is the best value for money? So whenever we have introduced new diagnostic or new treatment, we need to see if the benefits coming from that treatment, it's worthy of the money we are investing in that treatment. So meaning if you have a treatment which will introduce to the patient better healing rate of 0.01% and cost 10 times more than standard of care, then we need to think about, is that worthy of investments? Should we invest such a lot of money just to get that tiny improvements? Or we need to look for the treatments which have a more moderate cost, but they are introducing better benefits for patient. Just with improving healing rate of the patient, we will already decrease the cost because healed wound cost much less than unhealed. Therefore, the only way to decide how to do, in which direction to take in this really complex situation, is to use decision analytic models, which we introduce also in the slide 1, in order to decide what is the best trade-off between benefits and harm for the patient first, And if the new treatment is have a good profile in that sense, then on second, to see if that treatment is also cost effective. So if that money we should invest, it's worthy of the value that that treatment is bringing to the patients. And therefore, we already start to answer the question why we need the models. So in the next slide, we will try to explain that question more in depth. So in this complex situation which we describe, in which we want to treat the patient on the really holistic way, on the best possible way for them, but on the other hand, we are practically pressured by cost constraints and budget constraints. So we need to decide how to approach this situation. But let's for now forget the budget and cost and just focus on clinical part. Making clinical decision about how to treat certain ulcer, especially in this kind of a holistic way, it's not easy, especially when we have so much different options and different intervention in the market, and we want to choose what is the best for our patient. And that is the first moment when we need the models, because models are not only to model cost effectiveness, as we described that at the beginning in terminology part. We also can model our decisions, clinical decisions, in terms of benefit harm assessment. So every new technology brings some benefits, but also some harm. We need to find that trade-off between those and to choose those who are the most beneficial for the patients in terms of both benefits and harms as well. And of course, no one is expecting that clinicians or nurse will develop the model in order to answer those questions. And that is the task of our researchers who should build those models and answer and publish those questions, answer it into the relevant channels for nurses and physicians in order to empower them and make their clinical decision easier. And once we have decide which treatments are better in terms of their benefit-harm trade-off, then in the next step, we will also run cost-effectiveness model in order to also see if this value bringing by new treatment is a good value for the investment money. And if it's not, maybe we can think about it that new technology should have the lower price, or even if it's bringing so much benefits and can save the cost, the manufacturer can be even encouraged to increase the price because it's still saving overall cost in the system. So that is the right way to thinking about this. It's not always about thinking just about budget or just about clinical part, but thinking about both in the same time. And why the models are good in this? Those are really complex situations in which you cannot use only one clinical study or one cost analysis, because in clinical studies, let's say even in RTCs, they are limited to a certain level to answer a really specific question. And in the real world circumstances, we have a lot of more complexity and more elements which it's not even answered in the single clinical trial. So the best way is to combine many different sources into the one model, which can then answer the question in the real world situation. And that is where the models are really good to be used. And I encourage you to read the article called "When Should Decision Analytic Modeling Be Used in Economic Evaluation of Healthcare?" Because it's not just about economic evaluation. You will see a lot about how you can use it for purely clinical question, why that is important. And also, in many times, we don't have a clinical trial for every single country and every single condition of interest for us to answer. So therefore, we need to transfer and very often need to extrapolate effects from the study to the broader population. And that is where the models are really good. And that is the right place to use the models in order to inform how to do a holistic approach to wound treatment. So how to get a maximized benefit for the patient with the existing budget. Now in this part 3, we want to give you more insight into the cost effectiveness model per se, because until now you already should get a grasp that cost effectiveness models are not only about cost, but a lot about benefit for the patient. So let's dive a bit deeper in that problem. So as we discuss, in the cost effectiveness models, we are using both benefits and costs. So we are not only interested in cost exclusively. So therefore, actually, we are first starting to model effectiveness or patient-related benefits, and then after that, we are starting to model the cost. Therefore, we are starting with really specific wound-related benefits for the patients. And you can recognize here a lot of the standardized outcomes for the wound healing as a proportion of reduction in size and reduction in complications and infections and quality of life and healing rate and time to heal. So all important. So those should be not all always in every model, but at least some of those must be in a good cost effectiveness model. And once we have those benefits in on the proper way in the model, then we can start to model the cost itself. And the cost, it's always modeled as a so-called opportunity cost. Not to go into too much details in that one, but practically that means you cannot spend €1 twice because you have a final budgets, and once you spend it for something, for some new treatment, you are losing opportunity to spend it to something else. So before you spend it, you think twice, you build the appropriate model, and you answer your question, what is your best value for money? Also, it's really important to understand one really frequently present misconception about the cost, because we are making equal sign between the cost and price of, let's say, dressing. That is not the same beast, so to say. When we say cost, we are thinking about a lot of cost during the patient pathway or patient journey of wound diagnostic and treatment and rehabilitation if needed. So we are taking all those elements into the account, not just the cost of dressing, let's say, which is sometimes it's only a 10% of complete wound healing process. So we took direct cost. By direct cost, we are referring to the costs which are directly medical cost of treatment of wound, which can be inpatient stay in the hospital, outpatient visits, tests, drugs, time of GPs, time of nurses, time of physicians, and any other cost which is needed to directly to treat the wound. But then also we are sometimes taking in account also indirect costs. So we want to see if that person is employed and he is missing the days on his job, how much that costs to the society, or how much the patient will spend from his own pocket to buy certain treatments or do some diagnostic checks for his ulcer. So all of those are taken in account, not just simply a price of one certain dressing. And of course, we are using official government sources for these cost elements in order to produce relevant analysis. Here we present several sources which are using in the UK, as for example, NHS reference cost or British National Formulary cost, etc. And here we want to present even more closer how we model new treatments in the care of hard to heal ulcers. As we can see here, we have a certain choice at the beginning on the left side, and we need to decide if we want to take treatment A or treatment B into account. And therefore, we are starting to ask ourselves, okay, what are the different costs associated with these two treatments, but also what are the different effectiveness or benefits and harms associated with those two treatments. And then we practically take in account all the costs, which we already explained in the previous slide, and the most important patient-related benefits, which also addressed in the previous slide. And we combine them together in order to compare, because cost effectiveness model, it's always comparable model. So you always comparing a new treatment versus something else. In the most of the cases, that something else will be actually standard of care, what you're already using for your treatment. And then on the end of the day, you are practically subtracting what is your standard of care now from what is that new treatment is, in both in terms of their benefits or effectiveness, but also in terms of their cost. And you get those deltas, which is telling you how much is the difference between cost of new and old treatment, and how much is the difference between effectiveness in the new and old treatment. Let's say effectiveness can be healing rate. So you get, let's say that the difference between those two treatments is, let's say, 3% of a healing rate. So new treatment giving you 3% better healing rate. And now the question is, and that we are answering with this, call it incremental cost effectiveness ratio, we are answering the question if this 3% of better healing time is worthy of that money. Once you divide those, so when you divide that cost, or difference in cost with that difference in effect or benefit, then you plot in that in one graph, which we have this on the right side, and depends in which part of the graph that results will lie, you will then decide if this is a good value for money or not. The interpretation is really simple, actually. On this x-axis, you have here benefits are depicted in the way of quality of life, and the y-axis is actually cost. So if the certain treatment costs more, but in the same time it's providing us with less effect, so that is this orange box, we will then say, okay, no, thank you. You are not improving the care of our patient. In the same way, you are cost even more. So we don't want that treatment. Then do we want the treatment in the green? I think so, no, as well, because treatment in the green, even it's cost less, it's bringing them less benefits for the patient. So we are not interested in anything which is bring the less benefits for the patient. So therefore, we want to focus ourselves only on those pink and dark blue parts of the graph. So we want to only take in account when the benefits for the patient are bigger. Then we have two scenarios. If the benefits for the patient are bigger and in the same time that new treatment costs less, then it's really easy decision. We can say that is this dark blue part. We say, okay, we have a better treatment for less money. The decision is really simply to go for that new treatment. But sometimes, and in the most of the cases, actually, we can be in this pink part when you actually have more benefits for the patients, but the costs are also higher. And that is the part of the trade-off. So then we need to answer the question if these benefits bring it by the new treatment, it's worthy of this increased costs. So therefore, we set up something which we call willingness to pay threshold. It's specific for the country, in which countries say, okay, this is how it's my willingness to invest even more in treatment according to the benefits it brings. This is example for the UK. They have two thresholds for that one, and they say, okay, if the treatment is increasing the cost 20,000 pounds per unit of effect, let's say that can be healing rate percentage, or in this case it's a quality or quality of life, then we are ready to pay that in order to improve the patient benefits. That is something which we want to pay more, and that is also cost-effective option. So everything which is below this threshold, then it's still cost-effective. So cost-effective is not only the option which is a cost saving, meaning that only reducing the cost. You can also increase the cost but if that is a worthy of benefits you bring, that therapy also will be cost effective. And that is a really important to understand, because this is really often a misconception about cost effectiveness, that treatment must be cheaper or the overall cost of treatment must be cheaper. No, we are happy to increase it, but only when the benefits that new treatment is bringing is a good value for that increase in spendings. So that is the essence of interpretation of the cost effectiveness analysis. At the very end, I want to thank you for your participation at this webinar, and I hope so we will have fruitful discussions on those topics. And also we give our best to explain really complex topic on the plain language, and hopefully this will add some clarity to why we need health economics model in the wound care. And I also encourage you that you read this international expert group working document, which is explaining in really non-technical language the same topics which we try to understand better today. It's really a good document, and it's resolving many misconceptions in this area in hard-to-kill ulcers. Thank you again very much, and talk to you soon during the discussion sessions.